moving on to treatment then. So for your dilatory dysfunction patients who are obstructed, what does your treatment algorithm look like? Medical, surgical, procedural, what kinds of things are you offering patients?
Well, so we're certainly looking for medical treatment first. So any underlying etiology, especially if they're smoking, really try hard to get them to stop if they are serious about treating the condition. We do a tremendous amount of allergy testing. I send them out for that. I'm big on if it comes back, it's all negative. We understand it doesn't mean they don't have allergies. We just haven't been able to nail it down. We will sometimes request intradermal testing to go with that one step further. So we're really, really big for anybody who's 6 or older, and especially the adults. There's a very high prevalence of allergies in that population, and that may be etiologic. So we're quite aggressive about that, rhinosinusitis, all these other things. We want to treat them, and the majority get better without surgery. We reserve the surgery for those failures.
As far as topical steroids, it seems like distribution of topical nasal steroids to that, getting all the way back into the nose seems like that would be difficult. Do you ever try any sort of other types of tricks to try to be able to get medications to the back of the nose so that they're treating that mucosa of the eustachian tube specifically?
Yeah, that's a very significant issue you're bringing up. So the nasal steroid sprays are beneficial in allergic rhinitis, and so we do have a lot of patients taking those. But you're right, it doesn't truly get all the way back to the nasopharyngeal orifice of the eustachian tube. Occasionally, I've used one of those. I'm blanking on the name of it now, but the newer device where you're, is it Optinose?
When you're blowing into your
Yes.
nose?
Yeah,
Xhance is the brand name. When you kinda
Xhance is it?
You
Yeah.
put, the one piece in your mouth, one piece in your nose, and you're kind of blowing the medication into the nose.
Right. Yeah. So, and some folks who I thought it was really good to go that extra step, we have done that, and I think anecdotally the results have been better. But as you know, that's a lot harder to get through insurance.
Yeah, for sure. And how long of a trial do you want patients to try their medical therapy before you say, okay, it's time to move on and start thinking about other options?
I'm usually giving them 6 weeks.
As far as reflux, are you managing reflux as well if you think that could be the contributor, or are you having them see GI or do any other testing?
I'll get them started on antacids and or PPIs, but I certainly ask them to follow up with their primary or GI or their referring otolaryngologist.
Hmm. And what about devices like an otovent or an ear popper? Like, are those helpful for them to be doing in the meantime, or is it helpful for them to practice a modified Valsalva 3 times a day per se? Like, are those types of things helpful for a patient that's got obstructive type symptoms?
Yeah, we love those. The mechanical devices, there's good evidence that they do work. So the balloon we use in the kids, and it really can make a difference. The adults don't like the balloon. Looks funny on an airplane. So the Eustachian or ear poppers, for the folks who just cannot coordinate a modified Valsalva, that is a go-to device that we frequently will recommend. They become much more affordable.
Mm-hmm. And are you having them do it just as needed when they have symptoms, or is it something where it could benefit from them doing it daily for a while?
Yeah, it depends. If we are contemplating surgery, like a balloon dilation, and they really want to try maximal conservative efforts, then I'll have them do it, 3 times a day or more if they want. Others, if they find that, hey, that works for me, I only need it on an airplane, great. They take it along on the plane.